Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'll be doing another Kahoot, and I'm going to go over critical care nursing. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and press the like button now so you don't forget. Subscribe to my channel if you haven't done so already, and don't forget I'm now offering next generation NCLEX reviews and one-on-one private tutoring sessions and consultations. You can reserve your spot by going to my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, such as TikTok, Instagram, and Facebook. My handle is the same everywhere, Nexus Nursing. Now, without any further ado, guys, let's get started. Critical care nursing. What should be your nursing intervention for the patient in the ICU with a diagnosis of anxiety related to ICU and sensory overload? Here are your choices. Offer flexible visiting schedules for caregivers. Eliminate unnecessary alarms and overhead announcements. Administer sedatives to promote rest. Or allow the patient to do as much for themselves as possible. What should be your nursing intervention for the patient in the ICU with a nursing diagnosis of anxiety related to the ICU and sensory overload? I spelled overload wrong, forgive me. If you didn't make it into the Kahoot and you're on the live, you can just press your type in your answer on the live. Okay, good. Most of you guys chose the correct answer. You're going to eliminate unnecessary alarms and overhead announcement. Now, the clue should have been unnecessary, right? That now this patient, their nursing diagnosis, they're having anxiety because there's too much stimulation. So you want to decrease the stimulation. You want to have that patient's room away from the nurse's station, because the nurse's station is when, the doctors are giving orders, the healthcare providers are giving orders, the nurses are giving reports, family members are there asking questions, the phones are ringing, fax machine, there's so much going on. So you want to have them at the end of the hall. You want to make sure people aren't pacing up and down the hall. You want to make sure there isn't a lot of light, there isn't a lot of noise. You want to decrease stimulation, okay? And in nursing, we always go from least invasive to most invasive. Look at the other choices. 9 of you chose offer flexible schedules, visiting schedules, and caregivers. You know what that means when you're offering flexible visiting schedules for caregivers? That's wonderful for the caregivers. Their schedules are flexible, but that means people can be going in and out day and night or more often, and you're trying to decrease stimulation, not increase stimulation. So that can't be the answer. And the next choice says administer sedatives to promote rest. 12 of you guys chose that. We may have to do that, but that is not going to be our first option. We always want to go from least invasive to most invasive. So before we try medicating the patient, before we try sedating them, let's try decreasing the environmental stimuli. And the last choice, allow the patient to do as much for themselves as possible. This is a beautiful answer for another question. Because in nursing, we always want to promote independence. We always want the patient to do as much for themselves as possible. This is true, but it doesn't answer our question. What does that have to do with decreasing stimulation? What does that have to do with the patient's diagnosis of anxiety related to sensory overload, right? Absolutely nothing. So the correct answer is going to be to help decrease the sensory overload. All right, what factor will cause a decrease in cardiac output? Is it decreased afterload, decreased heart rate, increased stroke volume, or decreased systemic vascular resistance? What do you guys say? Very good. Most of you guys chose the correct answer. Decreased heart rate, that will decrease the cardiac output. All of the other choices, decrease afterload, increase stroke volume, decrease systemic vascular resistance, those three actually increases cardiac output, not decrease. So the correct answer is decreased heart rate. Why should the critical care nurse include caregivers of the patient in the ICU as part of the healthcare team? Why would that be important? Is it to decrease the cost of care? Is it that caregivers play a valuable role in recovery? Is it that caregivers can take over the responsibility of decision making? Or is it that the patient will be less likely to doubt the quality of care provided? Why is it important to include the caregiver as part of the healthcare team in the ICU? Very good. Most of you guys chose the correct answer. And caregivers play a valuable part in recovery. Where do you think that recovery is going to be taking place? At home? Yeah. So the caregiver plays a very valuable part. So it's important to have them involved. The first choice, to decrease cost of care. I'm so happy nobody chose that. I'm so proud of you guys. Whenever you guys are testing and you're trying to figure out what the correct answer is, it's never the answer that has to do about money, that has to do about cost, okay? When you are testing, there are 5 things that should never be considered when you're trying to figure out what the right answer is. And one of them have an exception, but I'm going to explain that to you. What are those 5 things? Cost. That shouldn't be a consideration because when you're testing, it's a perfect world. You have enough money to do whatever you need to do for your patient. Money. The amount of staffing. In the real world, we're concerned about that. That can dictate how we move. Not in the testing world. We have enough staff to do whatever we need for our patient. Resources, equipment, and time. Let's talk about the 5th one because when it comes to time, there is an exception to that rule. We don't consider time in the testing world. We have enough time to do whatever we have to do for our patient unless it's an emergency. So, for example, if the patient has a perforation of an organ, that's a medical emergency. Time is of the essence. We have to get that patient into the OR ASAP, or guess what? That patient's going to die, right? So, unless it's a medical emergency, time is not of the essence. The only time is considered is if it's a medical emergency. But those 5 things that I mentioned, money, staffing, resources, equipment, and time should not be considered when you're trying to figure out what your answer is, except, again, when it comes to time, if it's a medical emergency, then you should consider time. Other choices, caregivers can take over the responsibility of decision-making. 3 people chose that, and that's not true. Unless the patient has some type of condition where they have a cognitive deficit or something's going on that they can't make decisions for themselves, that's not true. And guess what? That's not why we would involve the caregiver. We're involving the caregiver because they're going to be a valuable part of recovery anyway. And the last choice, 2 people chose this, the patient will be less likely to doubt the quality of care provided. Even though this is true, when we get the caregiver on board, it is true that the patient will be less likely to doubt care provided, but that's not why we're doing it. The reason we're doing it is because we know they're going to play an integral part of recovery when that patient goes home or even when that patient goes to rehab. Speaking of rehab, before I go on to the next screen, something NCLEX definitely expects you to know, you better know those preventative measures, the levels. First, primary, secondary, and tertiary. Primary preventative measures is when the patient does not have it and you want to prevent them from having it. So primary prevention measures would be things like education or immunizations. Secondary prevention measures, we think the patient has it. We're going to test the patient to see if they have it or to see how far along it is. That would be things such as colonoscopies or mammograms or biopsies. Tertiary prevention measures, patient has it. We just want to prevent it from getting worse. So that would be something like physical therapy or speech therapy or occupational therapy. Okay, so make sure you guys know the difference of those 3. How are you guys doing on the live? You guys still with me? Okay, very good. Let's keep going. Which nursing action contributes to an increased preload? Would you say it's administration of diuretics, administering increased fluids, administration of entropin, or administering calcium channel blockers? What do you guys say? Very good. Most of you guys chose the correct answer. And it's increasing fluids. You increase fluids, you expect the preload to be increased. Now let's look at the wrong answer choices. Administering diuretics. Diuretics makes you do what? It makes you lose fluid. So we would expect that preload to be decreased. By the way, guys, preload is that force that stretches that cardiac muscle before contraction. That's what preload is. So you give a patient diuretic where they're going to be losing fluids, you're going to expect to see the opposite. You're going to expect to see preload decrease. Administering entropin, that's dopamine, that really doesn't affect the preload, but you do expect to see it decrease, increases. Oh my gosh, guys, I can't think. Dopamine, you expect it to increase the contraction. I can't think. Increase the contraction. And last, calcium channel blockers. Calcium channel blocker, you know, it's a type of antihypertensive. And that also, guys, you don't expect it to really mess with the preload, but you expect it to decrease contractility, okay? So the only one for this that you would expect preload to be increased is giving the patient more fluids, and it makes sense. More fluids, right? More pressure being exerted. So that would be more pressure pushing against those muscles before contraction. And so fluids is a correct answer choice. Thank you, Irene. All right, I'm preparing the patient for insertion of a pulmonary artery catheter. What should the nurse do? Place the patient in high Fowler's position, obtain an informed consent from the patient, assess for a positive Holman sign, or ensure the patient has continuous ECG monitoring. What do you guys think? Very good. Wait, 28 of you guys chose, no, not very good. I take that back from you guys. Obtain an informed consent from the patient. Have you guys lost your ever-loving minds? Okay, first of all, I'll tell you what the answer is, and let's talk about why that's the wrong answer. The correct answer, which only 2 of you guys chose, was ensure that the patient has continuous ECG monitoring. And that is important because that pulmonary artery catheter is being inserted, patient's going to be at risk for dysrhythmias. So we better make sure that there's continuous ECG monitoring. Let's talk about the wrong answer choices. The red where it says place the patient in high Fowler's position. No, that patient's going to be placed flat. Okay. Their head's going to be flat. Assess for a positive Holman sign. That has nothing to do with that. We're even concerned about Holman sign when it comes to maybe something like a possible thrombus. And then obtain an informed consent from the patient. All right, guys, everybody on the live, who gets the consent from the patient? I'll give you guys a second. I want you to type it in. Who gets consent? The provider. The healthcare provider. Your job as a nurse is to witness the consent and make sure that consent goes in the chart. Okay? That is your job. You do not get consent, because in order to get consent from a patient, you want to know what you're doing? You're explaining the procedure. You're letting the patient know that they're at risk for dysrhythmias, especially as that catheter is going through the right ventricle. Okay? The healthcare provider is explaining that. The healthcare provider is explaining to the patient all of the risks of having this procedure done, everything that can possibly happen if they refuse the procedure, the intricacies of the procedure. That is the job of the healthcare provider. Your job is to make sure that it was done and you were a witness to it. And you take that signed consent and you put in the chart. And when you go to put in the chart, if you notice that this patient was medicated with maybe a narcotic or something that would affect their cognition before they sign the consent, guess what you have to do? Call the healthcare provider and let them know, I'm so sorry, but this procedure is going to have to be rescheduled because guess what? That consent was not legal. Okay. But you do not get consent from the patient, the healthcare provider does. Make sure you guys know this because this is a famous, not this exact question, but this concept is a famous concept that NCLEX likes to ask about. They want to make sure you understand your scope of practice, what your role is when it comes to consent. It is not to obtain consent, it is to witness the consent and also apply that consent to the patient's chart. Okay, guys? All right. The nurse uses the minimal occluding volume technique to inflate the cuff on the patient that has an endotracheal tube. Why would this be done? Is it to prevent anemia? Is it to prevent infection? Is it to prevent necrosis? Or is it to prevent extubation? What do you think the answer is? Hmm. Wow. Most of you guys on the live, you did the same thing. You chose to prevent extubation. And the correct answer is to prevent necrosis because too much pressure on that tracheal wall, right? That pressure will decrease circulation, which decreases perfusion, which kills those cells, which causes what? Necrosis. Okay, that's why. All right, so when you're suctioning an endotracheal tube, the nurse should use a suction pressure of what? 40 to 60, 60 to 80, 80 to 100, or 100 to 120. What do you guys say? You guys are all over the place on the live. Only 5 chose the correct answer, 100 to 120. That is your range. Which nursing intervention should be included for the patient with an endotracheal tube? What are you going to do? Check the cuff pressure daily, keep a trach set at the bedside, hyperoxygenate before and after suctioning, reuse the suction catheter at the bedside daily. Very good. Most of you guys chose the correct answer. You are going to hyperoxygenate the patient before and after suctioning, okay? You're going to make sure that you have another catheter and bag valve at the bedside. And where it says reusing the suction catheter at the bedside, no, you're going to use a what's the word I'm looking for? Sterile. You're going to use a sterile catheter, or you can use the catheter that has that plastic sleeve so it can be changed. But definitely, no matter what, you better hyperoxygenate that patient both before and after suctioning. You guys are doing a good job. Select all that applies. Your patient's at risk for aspiration related to the presence of an artificial airway. So what are your nursing interventions going to be? Assess gag reflex, ensure that the cuff's properly inflated, suction the patient's mouth frequently, clear the vent tubing clear of condensed water, raise the head of the bed 30, 45 degrees unless the patient's unstable. Or at this point, Professor D, I give up. I don't know. Your patient has an artificial airway. They're at risk for aspiration. What would be appropriate nursing interventions? All right. I'm seeing you guys on the live. You are going to suction the patient's mouth frequently. You want to raise that head of the bed unless the patient is unstable, unless they have a condition where you can't. You want to ensure that the cuff is properly inflated, clear of vent tubing of condensed water. Someone says why not red? Assess gag reflex. Go back to the question. Look what it says. Patient has what? An artificial airway. What are you checking that gag reflex for? Tell me. The patient has an artificial airway in place. Right? Okay, good job. All right, last question, guys. Which medical diagnosis would you most likely expect the patient to need mechanical ventilation? Select all the apply. So what medical diagnosis would the patient have that you would expect that patient most likely to need mechanical ventilation? Sleep apnea, cystic fibrosis, acute kidney failure, type 2 diabetes, asthma, acute respiratory distress syndrome. Out of these diagnoses, which ones would you expect this patient to need mechanical ventilation, have to be on a vent? What do you guys think? Ashley says, how long will you be on this live? This is the last question, Ashley. I'm sorry. Okay, let's talk about it. 13 people chose sleep apnea, but no. With sleep apnea, they might have to be on a whatchamacallit night, a CPAP at night, but they wouldn't have to be on mechanical ventilation. Sleep apnea, that's when like at nighttime, there may be partial occlusion of the airway, like the patient's tongue may get in the way of them breathing, but that doesn't mean they would have to be on a vent. Cystic fibrosis, true. Think about it. Cystic fibrosis, this patient's making all of this thick mucus that is clogging up their lungs. They can't breathe. Patient with cystic fibrosis, it's very possible we would expect for them at some time to may have to be on mechanical ventilation. How about acute kidney failure? No. Patient going into acute kidney failure, we would expect they may have to be on dialysis, but not mechanical ventilation. Patient with type 2 diabetes, no, people live with type 2 diabetes every day. There's nothing acutely going on with them that their organs are failing, especially their lungs, that they would have to be on a mechanical ventilation. Just being a type 2 diabetic, we would not expect that. False. Being an asthmatic, we would not expect that. Asthma is a chronic condition. People will live with this every day. They may have exacerbations, but unless there's something acutely going on with that asthmatic, such as something happened and they went into acute respiratory distress, just being an asthmatic, that would not be a condition where you'd expect the patient to be on mechanical ventilation. So that's false. And last, acute, ding, 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 acute respiratory distress syndrome. Yeah. A patient in acute respiratory distress syndrome, where that patient is not breathing enough that those tissues can be perfused enough, that patient absolutely, we would expect them to be on mechanical ventilation. So for this question, it's just two: the patient with cystic fibrosis and the patient with acute respiratory distress syndrome. You guys did a wonderful job. Let's see who the top three are.